Stroke. Do you want to learn all about stroke? Have you ever seen a patient with symptoms related to stroke? Have you ever seen a person collapse or fall unconsciously with symptoms similar to stroke? Are you a medical student or a medical practitioner or anyone who should know the basics to treat stroke? Hello, my name is Muhammad Ali and welcome to MediStudy. Let's begin the video. By definition, stroke is a neurological deficit which is sudden due to an interruption or occlusion of the blood supply to the brain. It can ultimately cause deoxygenation and to the very extreme necrosis of the brain tissue, hence the neurological deficits. Now let's dive in and have a look at the types of stroke. Stroke can be categorized into two types: ischemic stroke and hemorrhagic stroke. In ischemic stroke, the narrowing or blockage can be due to an embolus or thrombus, and eventually you will be seeing infarction and necrosis of the brain tissues. It can be temporary or it can be permanent based on the type of blockage or narrowing. Hemorrhagic stroke is a type of stroke in which there is bursting of the artery which causes localized bleeding around the surrounding tissues. We previously talked about embolus, thrombus, and hemorrhagic stroke. But what are the causes that lead to stroke? The causes of thrombosis can be vasculitis, intracranial and extracranial atherosclerosis, blood disorders such as polycythemia. The causes of embolism can be atrial fibrillation, myocardial infarction, and cardiomyopathy. The causes of hemorrhagic stroke can be anticoagulant therapy, cerebral aneurysm, hypertension, and trauma. Here comes the main course. How would you even know if a person is suffering from stroke? For this instance, we'll always look for the signs and symptoms of stroke. Signs and symptoms of stroke are weakness or paralysis on the either side of the face, arm, or leg, or in combination. Blurred vision, slurred speech, difficulty in coordination and movement. If you observe any of these symptoms in a person, immediately call 911 or your local emergency helpline. It is very important for a stroke patient to get immediate medical support. According to the American Stroke Association, when it comes to stroke, time lost is brain lost. Every minute counts. Act fast. Let's talk about the risk factors of stroke. The risk factors of stroke can be divided into non-modifiable risk factors and modifiable risk factors. Non-modifiable risk factors include age, family history, gender, and race. Modifiable risk factor includes obesity, cigarette smoking, diet, and physical inactivity. Other than these, there are some major risk factors that can lead to stroke. These are hypertension, hypercholesterolemia, abnormal lipid profiles, some major heart diseases or renal disease. When a patient arrives at the emergency, the first thing which needs to be done is the CT scan ordered by a physician or neurologist. The CT scan is performed to rule out any intracerebral hemorrhage. However, ischemia or infarction is not visible up to 12 hours. On CT scan, infarction appears to be an area of low density, whereas hemorrhagic stroke appears to be an area of high density. This is helpful to differentiate the two types of stroke during diagnosis. Other than the CT scan, the physician or a neurologist will also order a complete blood profile, serum cholesterol level, echocardiography, chest X-ray, blood sugars, and in some cases, angiography. During the diagnosis phase, the physician or neurologist will often order an MRI. MRI can be more sensitive and it is used to identify cerebral ischemia as early as 30 minutes and infarction within 2 to 6 hours. The physical examination includes vital signs such as heart rate, respiratory rate, or blood pressure, functions of cerebellum, cerebral hemisphere, the sensory motor organs, the cranial nerves, eyes is evaluated. A sudden onset of symptoms with decreased level of consciousness is suggestive of cerebral hemorrhage. Symptoms such as the worst headache of my life or patient complaining as the worst headache of my life is suggestive of subarachnoid hemorrhage. Bilateral signs and symptoms are suggestive of brainstem lesion or massive cerebral involvement. There is an important test and measure during physical examination to diagnose stroke. The measure is called NIHSS scale, the National Institute of Stroke Health Scale. It is an important tool for the examination of impairments following acute stroke. The scale has been designed to discriminate between stroke subtypes and it can be completed in 5 to 8 minutes. Now let's talk about the pharmacological management. The drugs which are used at the time of emergency to maintain the symptoms and to regulate the body function. The drugs which are extensively used during stroke at the time of emergency are anticoagulants, thrombolytics, antiplatelet therapy, antihypertensive drugs, anti-cholesterol agents. If the symptoms worsens even after the pharmacological management and medical management, the neurologist will proceed to surgery. So let's talk about the neurosurgical management. Surgery may be indicated in the case of hemorrhagic stroke, where the primary focus is to repair the superficial ruptured aneurysm. There are a number of surgical procedures for stroke, out of which let's talk about carotid enterectomy. It is a surgical procedure used to remove fatty deposits from the carotid artery. It is a very useful procedure to prevent recurrent stroke and TIAs. It is remembered to note that it cannot be performed during acute stroke because altered pressure could subject to further damage to the ischemic areas. Another procedure is called the penumbra system. It is a device that uses a catheter and separator that is threaded to the site of the clot. It suctions and grabs the clot and aspirates the site. It is remembered to note that this system is only effective in the 8 hours window period during the onset of stroke. Lastly, let's talk about rehabilitation. Rehabilitation is a vast treatment process that aims in reducing disability and promoting independence. It may also help to reduce or even eliminate the stroke-related symptoms and other reversible complications through proper medical management and plan of care. The plan of care involves a team of specialized physicians, neurologists, nurses, physical therapists, speech therapists, language pathologists, and social workers. In the rehabilitation phase, we will be specifically talking about the physical therapy interventions. The physical therapists play an important role to select an intervention which focuses on the examination of impairments, activity limitations, and goals. The overall goal of an intervention is to improve the motor control and strength of trunk and limb to gain overall functioning for the daily life activities. Let's talk about the interventions to improve sensory function. The interventions to improve sensory function includes sensory training program, which consists of mirror therapy, repetitive sensory discrimination activities, repetitive task practice, bilateral simultaneous movements. Sensory stimulation consists of compression techniques, electrical stimulation, magnetic stimulation, and mobilization. Now let's talk about the interventions to improve flexibility and joint stability. Flexibility and joint stability interventions for upper extremity are scapula mobilization with passive range of motion exercises, elbow extension with passive range of motion exercises, control of edema and tonal changes with passive range of motion exercises. The intervention also include self range of motion exercises such as arm cradling and tabletop polishing. Interventions for flexibility and joint stability for lower extremity includes active contraction with combined stretching for plantar flexor spasticity or dorsiflexor weakness, hip flexor stretching assisted by a physiotherapist. Interventions to improve strength are progressive resistive strength training, use of exercise modalities such as free weights, elastic bands, and machines, gravity assisted exercises, gravity resisted exercises, and task oriented activities. Now let's talk about the interventions to manage spasticity, which is very common in stroke patients. The interventions to manage spasticity are slow rhythmic rotation of the limb with moving the limb to lengthening range to gain full range, weight bearing in kneeling to prevent spasticity of quadriceps, combination of rhythmic rotations and proprioceptive neuromuscular facilitation techniques for upper trunk to prevent trunk spasticity, active contraction of elbow to prevent elbow flexor spasticity, and lastly, active contraction of knee to prevent knee extensor spasticity. The use of modalities may also be encouraged before the treatment of spasticity. Lastly, let's talk about the interventions to improve gait. The interventions to improve gait includes walking forward, walking backward, sidestepping, crossed stepping, step up, step down activities, stairs climbing, walking in a community environment, dual task activities, and lastly, balance activities. Finally, the patient is discharged when reasonable treatment goals and outcomes are attained. For patients with incomplete recovery, a home exercise program is also initiated and long-term follow-ups are also scheduled. Well, this was it. If you want to learn more about stroke, you can also visit our website at www.medisteady.com, where we have covered in detail about stroke. If you find this video informative, please consider subscribing and press the like button. See you until next time.